Welcome to the Funnel Effect. Today we are diving deep into something, well, pretty specialized. Highly complex, actually. But it's absolutely critical for understanding the future of heart care.
We're talking about the mitral valve.
Yeah, the mitral valve, it's an amazing piece of biological engineering, really dynamic. But honestly, for doctors trying to intervene, it's like navigating a minefield.
Not minefield. Why so different from, say, the aortic valve?
Well, the aortic valve is relatively more straightforward, structurally speaking.
Yeah.
The MV, though, it demands a really deep, sort of three-dimensional grasp of its anatomy. It's just much more intricate.
Okay, so to help us navigate this, our source material for this deep dive is a really key clinical review. It's called Mitral Valve Anatomy, Implications for Transcatheter Mitral Valve Interventions. This was published back in Eurointervention in 2014. The authors are Jose L. Zamorano, Ariana Gonzalez-Gomez, and Patrizio Lanciolotti. And it's a foundational paper. It really set the stage for a lot of the thinking around these newer procedures. So our mission today really is to unpack all that technical detail. We need to get into the weeds of the MV's four main components.
Right.
And understand exactly why knowing every little detail is, well, non-negotiable for success, especially with these transcatheter treatments.
Millimeters matter, you're saying?
Absolutely. Millimeters, angles, tissue quality. It all has direct clinical consequences. We need to grasp that link.
Okay, let's start with the big picture then. The clinical problem driving all this innovation, mead regurgitation. Marco, why is this becoming such a bigger issue now?
Fundamentally, MR is just a leaky valve. Blood flows backward when it shouldn't, and it's one of the most common types of valve disease we see.
And it's increasing, even though things like rheumatic fever are less common.
That's the paradox. Rheumatic disease is down, thankfully. But overall, MR prevalence is actually soaring. The main reason. It's pretty simple. We're all living longer. Population aging.
Just how big is the problem in older folks?
It's quite significant. The authors cite data suggesting something like 10%, 1 in 10 people age 75 or older has significant MR.
Wow, 10% over 75.
Yeah, and think about the sheer number of people in that age group worldwide. It's a huge and growing patient population needing treatment.
And it's not just a minor leak. Significant MR, if you leave it untreated, it really impacts survival rates, doesn't it?
Dramatically. It's not benign at all. The leak forces the heart to work much, much harder. Blood flows back into the left atrium when the ventricle contracts, so the heart pumps less blood forward effectively.
So the main pumping chamber, the left ventricle, the LV, it has to compensate.
Exactly. It tries to compensate by working harder, getting bigger, remodeling, we call it. But over time, that leads to dilation, weakening, and eventually a pretty severe heart failure. Untreated severe MR has very poor outcomes.
Okay, so given how serious it is, we need to understand what's actually failing. The source talks about two main types of MR.
Yes, and this distinction is absolutely crucial. It dictates the entire treatment strategy. First, you've got organic or primary MR.
Organic primary.
This one is maybe easier to picture. The problem is intrinsic to the valve itself. Something is physically broken or damaged.
Like a torn leaflet, or one of the little cords snapping.
Precisely. A torn leaflet, maybe from degeneration, or ruptured chordae tendineae, those are the cords. The structure itself is faulty.
Okay, that makes sense. What's the second type, the one you said is often trickier?
That's functional or secondary MEPR. This is different. Here, the valve leaflets and the cords, structurally, they might actually be perfectly normal. No tears, no damage.
So why is it leaking then?
The leak happens because the environment around the valve has changed. The heart's overall shape, its geometry has been distorted.
Usually because of the left ventricle.
Almost always. It's typically due to advanced left ventricular remodeling, maybe from a previous heart attack or chronic heart failure, causing the ventricle to dilate and change shape.
I see. So in functional MR, the valve structure itself is okay, but the sick, enlarged heart pulls it out of alignment.
That's a great way to put it. It gets pulled out of alignment, preventing the leaflets from closing properly, what we call coaptation. So failure of coaptation due to external forces.
Okay, both types sound serious. So why isn't surgery the default answer for everyone? I thought MV repair surgery was the gold standard.
It absolutely is the gold standard treatment for severe chronic MR, especially when it's causing symptoms. Repair is generally preferred over replacement too. But, and this is the crucial point, this is where the whole transcatheter field really found its purpose.
The surgical dilemma.
Exactly. The dilemma is that a huge number of patients who really need that valve fixed, maybe up to half of them, are actually considered too high risk for traditional open heart surgery.
Half. That's a massive gap in care.
It is a huge unmet need.
What makes them too high risk? What are the main factors?
It's usually a combination of things. Often it's advanced age itself, but also they frequently have other serious health problems, comorbidities we call them.
Like kidney problems, lung disease.
Yeah, chronic kidney disease, severe COPD, maybe they've had stroke before, things that make major surgery much more dangerous. And crucially, many of these patients already have significant left ventricular dysfunction. Their heart muscle is already weak.
So putting them through the stress of open heart surgery, cardiopulmonary bypass, it's just too much.
It's often deemed too risky. The potential harm outweighs the potential benefit of the surgery itself. The recovery is also incredibly demanding.
Okay, that really clarifies it. That's the aha moment, isn't it? This huge group of high-risk patients needing treatment but unable to get surgery.
Yeah.
That's the whole reason these transcatheter approaches were developed.
Precisely. That surgical gap is the engine driving innovation like the Mitral or these annuloplasty devices we'll talk about. The goal is to achieve the same mechanical fix as surgery, maybe closing the leaflet gap or tightening the valve ring, but doing it through a small catheter inserted through a vein or artery.
Avoiding the big chest incision, avoiding the heart-lung machine.
Minimizing the trauma, minimizing the stress on an already frail patient, offering a therapeutic path where none existed before.
And none of this is possible without incredible imaging, right? You need to see exactly what you're doing.
Imaging is everything. It's the foundation. You can't plan, you can't select patients, you can't guide the procedure without it.
What are the main tools? Echo.
Echocardiography is the workhorse, especially 3D TE, that's transesophageal echo, where the probe goes down the throat. It gives amazing real-time views of the valve's structure and function.
But you also mentioned CT scans, multi-slice CT.
Yes, CT plays a critical complementary role.
What does CT show you that echo maybe doesn't, or not as well?
CT is fantastic for mapping out the hard structures.
Right.
Its biggest advantage is detecting and precisely mapping calcification.
Calcium in the valve ring, the annulus, or on the leaflets themselves.
Exactly. Calcified tissue is stiff, non-pliable. Heavy calcification can be an absolute deal breaker for procedures like Mitral or direct annuloplasty where you need to manipulate or anchor into tissue. CT shows you exactly where that calcium is and how much there is.
And it helps plan the route in.
Absolutely. CT helps meticulously plan the access. For many procedures, you need a transeptal puncture punching a tiny hole between the right and left atrium. CT helps define the perfect spot for that puncture to get the right angle on the mitral valve.
Or for other approaches.
Or for a transapical approach, where you go directly through the tip, the apex of the left ventricle, CT helps find a safe window, avoiding coronary arteries. This pre-op planning is vital for making sure the catheter system can actually reach and be maneuvered into the precise 3D spot you need it to be.
Okay, understanding that environment, the need for precision, it brings us right to the anatomy itself. The source breaks down the MV apparatus into 4 key parts. Let's start with the foundation. The mitral valve annulus, the ring.
Right. Though calling it just a ring is a bit simplistic, it's the attachment point, this sort of D-shaped opening connecting the left atrium, left ventricle, and the valve leaflets.
And you stressed earlier it's dynamic.
Yeah.
Why is that so important to remember?
Because it's not static. Its shape and size change constantly throughout the heartbeat.
How so?
It actually constricts, gets smaller, during systole when the ventricle squeezes to help the leaflets seal tightly. Then it relaxes and widens during diastole when the ventricle fills to allow maximum blood flow through.
So if you treat it like a fixed, rigid structure.
You miss the point. You don't appreciate the forces involved or how disease might affect that normal dynamic function. Understanding that dynamic nature is key for designing repairs that last.
And its 3D shape is complex too. The paper calls it saddle-shaped. What does that mean and why does it matter?
Imagine a horse's saddle. It's not flat, right? It curves up at the front and back and dips down at the sides. The mitral annulus is like that. The anterior part, near the aorta, and the posterior part are the high points, the pommel and cantle of the saddle. The sides, medial and lateral, are lower.
What's the benefit of that weird shape?
It's thought to be optimal for function. That complex, non-planar shape probably helps minimize stress on the leaflets as they open and close, and it helps them co-opt or meet effectively without bulging too far back into the atrium.
And standard 2D echo might not show that well.
Exactly. 2D echo can sometimes flatten that view, make it look planar when it isn't. That's why 3D imaging, like 3D TE or CT, is so vital for really appreciating that saddle shape before you try to fit a device into it.
Now, you mentioned the annulus isn't uniformly strong. It has rigid parts and weaker parts. Where's the strong anchor point?
The anterior segment is the strong part. It's directly connected to the fibrous skeleton of the heart, specifically through something called the aortic mitral curtain.
The curtain connecting it to the aortic valve.
Yes, it's a sheet of tough fibrous tissue, and this connection is reinforced at the ends by the right and left fibrous trigonos. Think of these trigonos as dense collagenous anchors. They make that whole anterior part very stable and resistant to stretching or dilating.
Okay, so if the front is rigid, where's the weak spot? And what happens there?
The posterior mitral annulus is the weak link in the chain. Unlike the anterior part, it's not anchored into dense fibrous tissue. It's more loosely attached to the surrounding muscle of the atrium and ventricle.
Ah, so it doesn't have that strong fibrous backbone.
Exactly. It's more flexible, but also much more susceptible to problems.
Which explains.
It explains why, when things go wrong, like the left ventricle starts to dilate in heart failure, the stretching and failure tend to concentrate on that posterior segment.
I see. The weak part gives way first.
Precisely. Annular dilatation, the stretching of the MV ring, almost always happens predominantly in that posterior segment. It widens the valve opening, particularly side to side, the septal-lateral dimension.
And that pulls the leaflets apart.
It pulls the leaflets apart, reduces or eliminates their ability to cope properly, and boom, you get functional light. MR calcification also tends to deposit more heavily in this posterior segment over time.
So basically, any repair strategy, surgical or catheter-based, has to focus on fixing that stretched out posterior weak link.
That's the primary target. You need to shorten it, stabilize it, reshape it somehow, bring that posterior segment back into line to allow the leaflets to close again.
Okay, focusing on that posterior annulus immediately brings up its neighbors. You mentioned these are critical because they pose risks during interventions.
Yes, the posterior annulus lives in a crowded neighborhood. Two very important vascular structures are right there. The first is the coronary sinus.
The coronary sinus, that's the big vein draining blood from the heart muscle itself, right? And it runs along the back of the heart.
Exactly. It runs in the groove between the atrium and ventricle, wrapping right around the posterior aspect of the mitral annulus, very close neighbors.
And its location gave people an idea for a minimally invasive fix.
It did. It led to the whole concept of indirect annuloplasty. The thinking was, hey, this vein is right next door to the part of the annulus we want to tighten. What if we put a device inside the vein?
And cinch the vein to indirectly squeeze the annulus.
Exactly. Put a stiffening rod or a contracting device into the coronary sinus, activate it, and hope it pulls the adjacent posterior mitral annulus inward, reducing the dilatation and then MR.
Sounds clever. Almost too clever. What's the catch? You flag and challenge.
The big catch is anatomical variability. The exact distance between the coronary sinus and the actual plane of the mitral annulus varies a lot from person to person. And worse, in patients with significant MR, the very dilatation you're trying to treat often stretches the annulus away from the coronary sinus. So the vein might end up being too far away for a device inside it to have any meaningful effect on the annulus itself.
So the anatomical relationship you're relying on is often distorted by the disease itself.
Precisely. The premise breaks down in the very patients you want to treat. And then there's the second critical neighbor, the circumflex coronary artery.
Okay, that's a major artery supplying blood to the side and back of the heart muscle.
And it usually runs very close to, sometimes almost parallel with, the coronary sinus, right in that same groove near the posterior annulus.
I think I see the problem.
If you put a strong constricting device into the coronary sinus to squeeze the annulus,
You risk squeezing the circumflex artery shut at the same time.
bingo. Extrinsic coronary artery compression. It's a catastrophic risk. You might fix the valve leak, but cause a massive heart attack by cutting off blood supply through the circumflex.
Okay, that's a huge red flag. No wonder those indirect techniques have struggled.
It's a major limitation. That risk, combined with the anatomical variability affecting efficacy, is why indirect annuloplasty hasn't really become a mainstream solution. The risk-benefit calculation is tough.
Right. High stakes indeed. Let's move from the ring itself to the parts that actually move. The mitral valve leaflets, there are two main ones, anterior and posterior.
Yep, two leaflets, but they are quite different in shape, size, and function.
Tell us about the anterior leaflet.
The anterior leaflet is often called the aortic leaflet because of that fibrous continuity we talked about, the aortic mitral curtain. It's the bigger, stronger one. It's kind of trapezoidal in shape, significantly larger area, thicker, and longer than the posterior leaflet. It does a lot of the work in closing the valve.
But even though it's so big, It only attaches to about a third of the ring's circumference.
That's right. It covers roughly the anterior third of the annulus perimeter. It's like a big mobile sail covering a relatively narrow attachment base.
Okay, so what about the posterior leaflet?
The posterior leaflet takes up the other two-thirds of the annulus circumference, so it has a much wider attachment base.
It's shallower.
Much shallower, yes. Less mobile, too. It acts more like a buttress against which the larger anterior leaflet closes.
And it often has indentations, right? Clefts.
Yes, that's a key feature. The free edge of the posterior leaflet isn't usually smooth. It typically has two indentations or clefts that divide it visually into three sections, or scallops. This is normal anatomy, not necessarily pathology.
And that leads us to the scallop system. This is just a way to talk precisely about where on the leaflets a problem might be.
Exactly. It's a standardized nomenclature, like a map. We virtually divide both leaflets into three segments or scallops.
A1, A2, A3 for the anterior.
Right. A1 is the lateral or anterolateral scallop, A2 is the central one, and A3 is the medial or posteromedial one, near the septum.
And P1, P2, P3 for the posterior.
Correspondingly, yes. P1 is opposite A1, P2 is the large central scallop opposite A2, and P3 is opposite A3.
So a cardiologist can say there's severe prolapse of P2.
And everyone knows exactly which segment of the posterior leaflet is flapping loose. It's essential for communication and planning, especially for repairs like MitraClip that target specific scallops.
Let's talk about how they close, the coaptation zone. This isn't just about the edges touching, is it? They need to overlap.
Absolutely crucial point. They don't just meet edge to edge. They need to overlap substantially to form a reliable seal against the high pressure in the ventricle.
How much overlap is normal? The source mentions a specific height.
Yeah, the source notes that in a healthy heart, the leaflets typically coapt or overlap over a height of about 8 millimeters during systole on average.
8 millimeters. What's the significance of that number?
That 8 millimeter represents the valve's built-in coaptation reserve. Think of it as a safety margin.
A buffer.
Exactly. If the annulus dilates a little bit, or if the leaflets get pulled down slightly by tethering, the valve can use up some of that reserve overlap and still maintain a seal.
But if that reserve is lost?
If the disease progresses severe dilatation, leaflet destruction, or significant tethering, and you lose that coaptation reserve, that's when the valve starts to leak significantly. The leaflets just can't meet properly anymore.
And understanding that reserve is important for interventions.
Vital. Procedures like MitraClip, for example, fundamentally rely on having some remaining leaflet tissue and coaptation surface to grasp onto. If the reserve is completely gone, the procedure might not be feasible.
That detailed anatomy really sets the stage for understanding the repair strategies. Section 3 in the source covers transcatheter annuloplasty procedures. These focus on fixing that stretchy annulus ring.
Right. The goal here is to mimic what surgeons do with an annuloplasty ring, surgically sewing in a ring or band, usually along the posterior annulus, to shrink its diameter and restore its shape. Transcatheter methods try to do this less invasively.
We touched on the two main flavors, indirect and direct. Let's revisit indirect annuloplasty, the coronary sinus approach.
Okay, so devices like Carillon or Monarch fit here. The idea, again, is to thread a device through the veins into the coronary sinus, which lies near the posterior annulus. Once it's in position along that posterior curve, the device is activated. Usually it contracts or creates tension to shorten the coronary sinus segment.
And the hope is that shortening the vein pulls the adjacent annulus tissue inwards.
That's the theory, indirectly remodeling the annulus via the neighboring vein.
Why was that idea so appealing initially, apart from being clever?
The big appeal was the access route. It's entirely venous. You go in through a vein in the leg or neck, navigate up to the heart, into the coronary sinus. Relatively straightforward vascular access, potentially lower risk because you're not puncturing the septum or entering the high-pressure left heart chambers directly. It felt like the ultimate minimally invasive strategy.
But as we discussed, the anatomy threw up some major roadblocks. Variability in the CS annulus distance.
Yeah, that limits efficacy. If the vein isn't close enough, squeezing it doesn't help the valve much.
And you also mentioned device issues, mechanical problems.
Yes, that's another significant factor. The coronary sinus is a relatively thin-walled vein. It wasn't designed to withstand constant mechanical stress from a rigid or tensioning device placed inside it. So clinical studies often reported issues like device fracture over time due to the constant flexing with each heartbeat, or device migration, or even erosion through the vein wall. These durability concerns really undermine the long-term results.
And looming over all of it is the risk to that neighboring artery.
The circumflex artery. That risk of extrinsic coronary compression never goes away with this approach. You have to constantly check, usually with coronary angiography during the procedure, to make sure activating the device isn't pinching off that vital artery.
So variability, durability issues, and major artery risk.
It's a tough combination. It explains why indirect annuloplasty, despite the initial appeal, hasn't become the go-to solution. The benefits haven't consistently outweighed the risks and limitations.
Which naturally led researchers to think, okay, maybe we need to be more direct, leading to direct annuloplasty techniques.
Exactly. Devices like Mitral or Cardioband represent this direct approach. The goal is the same: remodel the annulus, but they try to do it by engaging the annular tissue directly.
How did it get there?
The access is usually more invasive, often requires a transeptal puncture to get into the left atrium, or sometimes a transapical puncture through the LV apex. From there, the devices aim to place anchors, sutures, or cinch down a band directly onto or very near the annulus, mimicking surgical ring placement more closely.
So they bypass the coronary sinus risks.
They do avoid the specific CS-related issues, yes. No risk of compressing the circumflex from inside the CS, for example.
But they introduce a whole new set of challenges.
Oh, absolutely. The technical difficulty goes way up. Now you're manipulating complex devices inside the beating left atrium or left ventricle.
What are the main hurdles?
While annular calcification becomes a bigger direct obstacle you might not be able to get anchors in, there's a risk of damaging the delicate valve leaflets or the chordae tendineae while trying to secure the device. And you still need to be extremely careful about the circumflex artery's location, because even approaching from the inside, it's nearby, especially near the posterior annulus attachment.
So it's potentially more effective, maybe more like surgery, but also technically much harder and carries its own risks.
That's a good summary. More direct, but more demanding. Development is ongoing, but it hasn't quite hit primetime universally yet.
Okay, if fixing the ring is that complex, maybe fixing the leaflets themselves is a better bet.
Which brings us to the most established transcatheter repair, the MitraClip system.
Right. MitraClip is definitely the leader in the percutaneous MV repair space right now. It's based on a surgical technique developed by Dr. Ottavio Alfieri.
The Alfieri stitch, or edge-to-edge repair.
Exactly. The surgeon would place a stitch connecting the middle portions of the anterior and posterior leaflets. MitraClip does the same thing, but percutaneously.
How does the device work?
It's essentially a small fabric-covered metal clip delivered via catheter. The goal is to navigate the clip between the leaflets, grasp the free edges of the central scallops, usually A2 and P2, and then close the clip, permanently holding those edges together.
Creating a tissue bridge in the middle of the valve opening.
Yes. It effectively transforms the single large leaky mitral orifice into two smaller, more competent orifices side by side, a double orifice valve. This immediately and often dramatically reduces the amount of regurgitation.
Sounds effective.
Yep.
But you mentioned it really changes the valve's geometry. It does, fundamentally. And because of that, patient selection based on very precise anatomical criteria is absolutely paramount. Maybe more critical for MitraClip than for almost any other cardiac procedure. Not everyone is a suitable candidate.
Okay, let's spend some serious time on these eligibility criteria. This is like the checklist from the source material that interventionists use. First up, the cause, the etiology of the MR.
Right. Rule number 1, what caused the leak? MitraClip is generally suitable for degenerative MR. That's the primary type, like leaflet prolapse or flail due to broken cords. It can also be used in carefully selected cases of functional MR, the secondary type, where the leaflets are stretched apart.
What makes someone unsuitable based on etiology?
Big exclusions are things like rheumatic heart disease, which causes thickened, scarred, and often stenotic leaflets that you can't easily clip. Also, infective endocarditis that has destroyed or perforated leaflet tissue. And congenital abnormalities like significant mitral clefts can make clipping difficult or ineffective. Basically, the leaflet tissue you intend to grasp needs to be reasonably pliable and intact.
Okay, makes sense. Next crucial criterion, the size of the valve opening itself. The mitral valve area, MVA, there's a hard cutoff.
Yes, a very important one. The MVA, measured usually by echo, must be greater than 4 square centimeters.
Why 4 centimeters specifically? Why is that the magic number?
Because when you place that clip in the middle, you are deliberately obstructing part of the valve orifice. You're making the total opening smaller.
Right.
If the valve is already small, or borderline small, say, only 3.5 centimeters to begin with, and you then put a clip in, you risk creating a new problem. mitral stenosis.
Stenosis meaning narrowing, restricting blood flow forward from the atrium to the ventricle.
Exactly. You fix the leak, but you create a blockage. That can be just as dangerous, causing pressure buildup in the lungs. The 4 centimeters cut off is the safety margin to ensure enough flow area remains after the clip is placed.
Got it. What about the leak itself, the regurgitant jet? Does its location matter?
Enormously. The ideal scenario for MetroClip is a single central jet of MR, meaning the leak is primarily occurring between the A2 and P2 scallops, right where the clip is designed to go.
So if the leak is off to the side.
If the main jet is highly eccentric, squirting way over near the A1, P1, or A3, P3 areas, the clip placed in the center might miss the main leak and won't be very effective.
What about multiple leaks?
Multiple jets all over the valve are also very challenging. A single clip usually can't address widely dispersed areas of regurgitation, so central jets generally have the best outcomes.
And obviously no heavy calcium right where you need to grasp the leaflets.
Correct. Significant calcification in the grasping area is a major contraindication. The clip arms need pliable tissue to secure a stable grip. Calcium prevents that.
Okay, those are the general rules. Now, the source mentions 4 very specific measurements from the T, transesophageal echo, that are crucial predictors of success. Let's break those down first. Coaptation length, minimum requirement.
At least 2 millimeters. This refers to the length or height over which the leaflets are currently overlapping, even if they're leaking.
Why do you need at least 2 millimeters of existing overlap?
You need enough tissue purchase. Think of it like needing enough fabric to get a good grip with tweezers. If the leaflets are only barely touching edge to edge, less than 2 millimeter overlap, the clip arms might not be able to securely grasp enough tissue from both leaflets.
Risk of the clip slipping off or not holding long term?
Exactly. It increases the risk of partial clip detachment or residual MR. So 2 millimeters is considered the minimum required leaflet tissue reserve for a durable grasp.
Okay, second measurement, coaptation depth. This relates to tethering. Maximum allowed depth.
Yes. This measures how far below the plane of the mitral annulus the leaflets meet or coapt. The cutoff here is no more than 11 millimeters.
So if they coapt 12 millimeters or 15 millimeters below the ring.
That indicates significant tethering, usually in functional MR cases. The leaflets are being pulled down deep into the ventricle by the distorted LV geometry and papillary muscles.
Why is 11 millimeter depth a problem for the clip?
Because the clip needs to bring those leaflet edges up to meet each other. If they're tethered down too deeply, more than 11 millimeter, the tension required to pull them together might be too great for the clip, or it might even tear the leaflet tissue. It basically marks the limit of how much tethering the procedure can reasonably overcome.
Makes sense. Now, what about cases with a flail leaflet, where part of it is loose because a cord broke? 2 measurements here, width and gap.
Right. If you have a flail segment, you need to measure its size. First, the flail width. This is the width of the unsupported leaflet edge that's flapping free. It must be less than 15 millimeters.
Why the 15 millimeter limit?
The standard Mitral clip is only so wide. If the flail segment is too broad, say 20 millimeter wide, a single clip placed in the middle of that segment might not be able to effectively capture the entire flailing portion and stabilize it against the opposing leaflet. You might get leaks around the sides of the clip.
Okay. And the second flail measurement, flail gap, maximum allowed.
The flail gap is the maximum distance the flailing leaflet edge separates from the opposing leaflet during systole. This gap must be less than 10 millimeters.
So they're flying more than a centimeter apart.
It suggests a very severe degree of prolapse or cord rupture. The clip has a certain reach, and if the gap is too wide, 10 millimeters, the clip might physically not be able to grasp both the flail edge and the opposing leaflet edge simultaneously. It's beyond the device's mechanical capability.
Wow. Those are incredibly specific anatomical requirements. It really highlights how tailored this therapy has to be.
Absolutely. These aren't just guidelines. They are strict criteria derived from clinical trials showing who benefits most and where the procedure is likely to succeed safely. Patient selection is key.
Okay, assuming a patient meets all those criteria, let's talk about guiding the procedure itself. It starts with getting access to the left atrium via the transeptal puncture. Location matters here, you said.
Critically important. This puncture, the small hole made in the septum between the right and left atria, is the entry point for the entire delivery system. Its location dictates the trajectory towards the mitral valve.
Where does it need to be?
It needs to be relatively posterior towards the back and superior towards the top on the interatrial septum, and at a specific height above the mitral annulus plane.
What happens if you puncture too low or too far forward?
It's a potential recipe for failure. If the puncture is too low or too anterior, The angle of approach for the MetroClip delivery catheter becomes suboptimal. You won't have the maneuverability needed to steer the clip effectively down towards the target A2P2 scallops.
You need the right line of sight, basically.
Precisely. You need a trajectory that allows the operator to align the clip arms perpendicular to the line where the leaflets coapt. A bad puncture site makes that alignment difficult or impossible.
And this is where advanced imaging inside the operating room, particularly 3D echo, becomes indispensable.
Absolutely. 3D TE is a game changer during MetroClip procedures.
How so? What does it show that 2D doesn't?
While 2D views, like short axis, bicobble, four-chamber, are essential for basic orientation and guiding the catheter, 3D echo provides the crucial and-face view of the mitral valve.
And face meaning.
Meaning looking directly down onto the valve from the perspective of the left atrium. You see the entire valve orifice, all 6 scallops, A1, A3, P1, P3, laid out like a map in real time.
That must be incredibly helpful for targeting.
It's revolutionary. The operator can see exactly where the clip is relative to A2 and P2. They can confirm the clip is centered correctly. And maybe most importantly, they can use the 3D view to ensure the clip arms are perfectly perpendicular to the line of coaptation just before grasping.
Why is that perpendicular alignment so critical?
If the clip goes on crooked, even slightly angled, the grasp on the leaflets will be uneven. That can lead to incomplete MR reduction, persistent leaks at the edges of the clip, or even potential tissue trauma. The end-face 3D view is the best way to guarantee optimal alignment for a successful, durable result. It really exemplifies the marriage of understanding complex anatomy and leveraging sophisticated imaging.
Okay, let's move to a final piece of the puzzle, section 5. The support structures underneath the valve. The subvalvular apparatus, tendinous cords, and papillary muscles.
Right. This is the intricate network that anchors the leaflets to the heart muscle itself. Its job is to hold the leaflets down during systole, preventing them from blowing backward into the left atrium under pressure.
Starts with the cords, the chordae tendineae.
Yes, these are strong, fibrous strings. They originate from the tips of the papillary muscles in the LV and insert onto the undersurface and edges of the leaflets.
The source distinguishes between 2 types of cords, marginal and basal.
Oh.
What's the difference?
Marginal cords are generally thinner and insert right onto the free edges, the very tips of the leaflets. Their main job is to prevent the leaflet edge from prolapsing or flailing upwards. If a marginal cord breaks, that specific edge segment becomes unstable.
Okay. And basal cords.
Basal cords, also sometimes called strut cords, are typically thicker and stronger. They insert further back from the edge onto the main body or belly of the leaflets, particularly the posterior leaflet.
What's their role?
They provide more general structural support to the leaflet body, but importantly, they also transmit forces from the papillary muscle movement, and LV geometry changes directly to the leaflet. They play a big role in how the leaflet position is affected in functional MR. They are also generally more extensible than marginal cords.
And these cords all attach down to the papillary muscles. Where are these located?
These are mounds or pillars of muscle that protrude inwards from the wall of the left ventricle, typically arising from the apical third of the ventricle.
There are 2 main ones.
Yes, the anterolateral papillary muscle towards the front and side, and the posteromedial papillary muscle towards the back and middle septum.
Now, the source highlights a critical difference in their vulnerability related to blood supply.
Yes, this is a really important clinical point. The anterolateral papillary muscle is usually the more robust of the 2.
Why?
It typically gets blood supply from 2 major coronary arteries, branches from both the left anterior descending, LAD, and the circumflex artery. This dual supply provides redundancy. If one artery gets blocked, the other can often keep the muscle alive.
Makes it tougher. What about the other one?
The posteromedial papillary muscle is the vulnerable twin. It usually has only a single blood supply, typically from a branch of the right coronary artery, RCA, or sometimes the circumflex, but rarely both.
Only one fuel line.
Exactly. So if that single supplying artery gets blocked, say, during a heart attack involving the RCA, which is common, the posteromedial papillary muscle is at very high risk of ischemia, lack of oxygen.
And if it becomes ischemic,
It can lose function, weaken, stretch, or even rupture completely. This is a very common cause of acute severe MR after a heart attack. The anchor point for the cords simply fails due to loss of blood supply. Ischemic MR often involves dysfunction of this specific muscle.
so that direct link between the LV muscle health and the valve function is critical, especially in functional MR.
It's the absolute core of functional MR. Remember, in FMR, the leaflets and cords might be normal, But the LV remodeling changes everything.
Remodeling meaning the changes in size and shape after injury
Yes.
or due to chronic failure.
Yes. As the LV dilates and becomes more spherical instead of conical, the papillary muscles get pulled further apart from each other and also displaced downwards away from the mitral annulus.
And that pulls on the cords.
It pulls hard on the cords and leaflets. This is MV tethering.
Tethering, like pulling the leaflets down on strings.
Precisely. This tethering restricts their normal upward motion during systole. They can't reach the midline to coapt properly, even if the annulus size itself hasn't changed much. The geometry of the LV dictates the failure of the valve. A coaptation gap opens up simply due to this pulling force.
Understanding that tethering mechanism has led to some really different intervention strategies, right? Ones that don't even touch the valve directly.
Exactly. If the root problem is the LV shape causing tethering, maybe the solution is to fix the LV shape.
Like the icoapses device mentioned in the source.
That's one example of an LV-focused technique. The icoapses involved placing epicardial pads on the outside surface of the heart, connected by a cord across the ventricle. Tightening that cord aimed to reduce the septal-lateral dimension of the LV.
Basically cinching the ventricle from the outside.
Yes, cinching the ventricle to pull the papillary muscles closer together, thereby reducing the tethering forces on the leaflets and hopefully improving coaptation and reducing the functional MR.
A very indirect upstream approach. Fascinating.
It really highlights how the MV doesn't exist in isolation. It's functionally integrated with the LV. Fixing MR sometimes means fixing the ventricle.
Okay, this brings us to the final and perhaps biggest challenge. Transcatheter mitral valve replacement, TMVR. We know transcatheter aortic valve replacement, TAVR, is routine now. Why is replacing the mitral valve percutaneously so much harder?
TMVR. It's often called the holy grail of structural heart intervention, and for good reason. It is vastly more challenging than TAVR, and it boils down to nearly every anatomical complexity we've just discussed.
TAVR works partly because the aortic valve sits in a fairly stable calcified ring, right?
Right. The aortic annulus is relatively circular, symmetrical, and the surrounding calcification often helps anchor the TAVR device. The mitral annulus is none of those things.
So challenge number one for TMVR. Anchoring the new valve.
Huge challenge. The MV annulus is D-shaped, not circular. It's highly dynamic, changing shape and size constantly. It's saddle-shaped, non-planar. And especially posteriorly, it lacks firm, fibrous tissue to anchor into.
So getting a prosthetic valve to sit securely and seal perfectly in that moving asymmetric ring is tough.
Extremely tough. You need significant radial force from the valve frame to hold it in place, but too much force risks damaging surrounding structures. Finding that balance and achieving a durable seal without migration is problem number one.
Okay, challenge number two, obstruction risks.
Yes, putting a bulky prosthetic valve frame into the mitral position creates immediate risks for neighbors that TVR doesn't really face. The biggest is LV outflow tract, LVOT obstruction.
How does that happen?
The anterior mitral leaflet sits right next to the path blood takes out of the LV to the aorta, the LVOT. A TMVR frame, especially if it's large or sits too anteriorly, can push that native anterior leaflet forward into the outflow tract, physically blocking blood from leaving the heart.
That sounds immediately life-threatening.
It can be catastrophic, causing cardiogenic shock. Predicting and avoiding LVOT obstruction is a massive focus in TMVR device design and patient screening using CT simulation. There's also a risk of the TMVR device interfering with the nearby aortic valve itself.
What about the existing cords, the subvalvular apparatus?
Challenge number 3, the tendinous cords. They are still there when you put in a TMVR.
And they get in the way.
They absolutely can. They can become entangled with the delivery system or the prosthetic valve frame itself. They can prevent the frame from expanding fully or seating correctly. They can interfere with anchoring mechanisms. Managing the native cords during TMVR is a whole extra layer of complexity compared to TAVR where there are no cords.
So you might need strategies to deal with the cords specifically.
Potentially, yes. Some approaches might involve resecting them, others try to work around them. It's an active area of investigation.
And finally, the problem of leaks around the valve.
Challenge number 4, paravalvular leaks, PVL. Because the MB annulus is so irregular and non-circular, getting a perfect seal between the prosthetic valve frame and the native tissue is very difficult. Gaps can easily form.
Are these leaks worse in the mitral position than the aortic?
Yes, generally much less well tolerated. The mitral valve sees lower pressures but higher flows over a longer duration, diastole. Significant PVL in the mitral position can lead to severe hemolysis, red blood cell destruction, and persistent heart failure symptoms. Achieving near-perfect sealing is more critical, yet harder to achieve with TMVR.
So anchoring, obstruction, cords, leaks. It really is a perfect storm of anatomical challenges.
It is. That inherent complexity of the native MV anatomy is the fundamental reason why TMVR development has lagged so far behind TAVR, despite the huge clinical need. Engineers are working incredibly hard to overcome these hurdles.
Well, that was an incredibly detailed journey through a very complex piece of anatomy. Let's try to summarize the main takeaways. We started with mitral regurgitation, a growing problem, especially in the elderly, creating a major surgical gap for high-risk patients. This gap is the driving force behind all these transcatheter innovations.
Right. And we learned that the key anatomical structure is the mitral valve annulus dynamic, D-shaped, saddle-shaped, and crucially with a weak, loosely anchored posterior segment that's prone to dilatation and failure.
Understanding the posterior weakness and its tricky neighbors like the coronary sinus and circumflex artery explains why indirect annuloplasty using the CS has faced major limitations regarding efficacy and safety.
Exactly. Then we dove into the specifics for MetraClip, the current leading repair technique. The absolute necessity for strict anatomical criteria became clear.
That checklist, MVA over 4 centimeters, central jet, no major calcification, and those specific measurements, coaptation length at least 2 millimeters, depth no more than 11 millimeters, and flail width and gap within limits, 15 millimeters and 10 millimeters respectively, non-negotiable for success.
And finally, we looked at the subvalvular system, the cords and papillary muscles, especially that vulnerable posteromedial papillary muscle with its single blood supply, making it susceptible to ischemia and explaining much of ischemic MR. Its connection to LV remodeling and tethering is key to functional MR.
All of which culminates in why TMVR is so difficult. Anchoring in that complex annulus, avoiding LVOT obstruction, managing the cords, and preventing leaks are all massive hurdles directly related to this intricate anatomy.
That's it in a nutshell. The mitral valve's complexity, its dynamic nature, its asymmetry, its intimate connection to the ventricle is precisely why these transcatheter procedures demand such meticulous planning, precise imaging guidance, careful patient selection, and why the field is still rapidly evolving.
So for a final thought to leave our listeners with, the source really emphasized that posterior annulus segment. It's the weak link, prone to stretching, sitting right by the coronary sinus and the circumflex artery, a dangerous neighborhood for interventions. Thinking ahead, what kind of breakthrough might allow us to safely reinforce just that flexible posterior segment? Could there be, say, an injectable biomaterial? Or a minimally invasive external support delivered perhaps via the pericardial space that could strengthen that wall without the current risks of vascular compression or needing complex internal devices? Solving that specific problem, safely reinforcing the posterior annulus, feels like it could unlock a whole new level of durable MR treatment.
That's a fascinating challenge, finding a way to buttress that specific area, respecting the nearby vessels. It would require real innovation in both materials and delivery. It's certainly where a lot of thought is going. Thank you for watching The Funnel Effect.